And now it's my pleasure to introduce Dr. Korva. You know for sure her, and she would tell you how the diagnostics of SARS-CoV-2 is now in the post-COVID era, as we should say, about a year from the officially ending the epidemic in the country. And what should we do now? What is ahead of us?
Hello, everybody, again. Yeah, I think it's very unfortunate title because I'm not sure that I can answer this sufficiently, but as you have seen in the previous presentations, we are building on quite a legacy of being a diagnostic laboratory, being a very strong zoonotic diagnostic laboratory, and being very strong respiratory virus laboratory. So I think with this epidemic and popularity of coronaviruses, and with all the knowledge that we built on in the past, I think we will see a much different future in regards of respiratory testing, not just in children, but also in adults. And I think there is many questions we still have to answer. But to take you over to bring you to the present, we first have to go back to the past, because it's really important to understand that Slovenia is a country of 2 million people. And it's a small Central European country. And like I said, we have a very good connections with different clinicians. We have a good system for microbiological diagnostics. We do a lot of diagnostics. And this was also the beginning of our epidemic story. So we introduced, as a part of Laboratory for Zoonosis, we introduced the test for SARS-CoV-2 very early. So in January 2020, we had everything ready. We believe that we are prepared for pandemic, like many, many countries around us. But then, of course, and this preparedness actually helped us in some way to combat the first wave of infections in Slovenia. So the first case was made in 4th of March 2020, which was later than our neighboring countries. So our politicians were quite worried about how good our preparedness system is, because everybody else had cases except Slovenia. And so they were not really trusting that we are doing the job right. But then we finally had this first case, and I think that a lot of us working in the laboratory was quite relieved, because we showed the concept, we showed that we are prepared. And because we had some information that these are really highly transmissible viruses, and we knew from the work that Monica presented and the Professor Petros explained to you, we knew that there is a lot of transmission between hospital staff and patients. Very strictly, very early on, very strict non-pharmaceutical measures like lockdown, not moving from the state of residence, locking the municipalities were introduced, and that really helped in the beginning of lowering our cases. So our first wave was actually a story of success, how you can stop the zoonotic disease transmission. But of course, like many success stories, there was a second wave, and we were just happy to quit, I would say. But here we had a relatively low number of cases and almost not many deaths. So we were very happy with our response. And in this first wave, we actually built on our experience in respiratory diagnostics. So we made like packages for sample collection. We publicized and made available a lot of instructions for sample collections. We ensured a lot of swabs, viral media, double packaging, and we gave this to different clinical institutions, also to the public health testing. But of course, because we are a small country, and because the numbers are usually not that big, everything was done manually. So this was one of the reasons, I would say, one of the first reasons why the second wave, when the requests and when the epidemic spread, why it was so hard on us, because everything was manual. Our sorting system was manual, our collection of samples was manual. So basically, in the beginning, it looks like that. We have employees working in the biosafety cabinets, and they have, I don't know if you see, but this is alphabetical order. So every swab that came in, they had to somehow translate it into the laboratory information system, and this was done by physically matching the name and the number, doing by alphabetical order. And this is okay when you have hundreds of samples. It's still a lot of work, but it's manageable. But then the second wave came. So this was our success story. And then we were very relaxed in the summer, and then this happened, and then this happened. So this was like a number of test requests that came to the laboratory in 1 hour. And now you have to unpack all this, and you have to sort by manually, and then you have to do the diagnostic. And of course, very, very early in this second wave of infections, we realized that without really building a laboratory capacity, like automated laboratory capacity, we will just die. Simply as that. And we are the main diagnostic institution in the country, and we knew that if we are not able to do that, none of the other laboratories that are supporting the local smaller hospitals will be even they would even have a harder job. So we really tried everything. We really tried to attack this problem from very different perspectives, and one of those was really trying to get the automated systems and different methods, PCR methods that would available very quickly in the beginning of pandemic. And you see that here also looks very optimistic and very good, because we got our first Korva's 6800 machine, and we switched from fully manual to almost fully automatic. But what I said in the beginning, we are a very small country with very limited our own production. And of course, here already the global pandemic really hit in, and this also was very, so that means that we were not able to get as many reagents we would need to do our diagnostics. And that's why, from being almost fully automatic and had a system that could really work, we had to go back, and there's more and more manual work to do, because in other ways we just couldn't get enough reagents and stuff to do the diagnostic, and the requests we got them. So we realized that we have a very serious need of actually employing more people to do more shifts. And on the other hand, to get access to the random access and the rapid diagnostic pipeline and diversify our pipeline in order really just to ensure enough different methods, different reagents, different pathways to actually do the diagnostic in time that would matter. Because on the other hand, if we wouldn't do that, then it means that the turnaround time would be prolonged, and then of course more transmissions, more cases, more severe epidemic. So this is what we did next. From almost fully automated, we had to go back to manual, and we have to diversify. This was the only strategy to really tackle that many samples. So by the end of 2020, and then by the first half of 2021, we had different platforms, and they were all interchangeably connected together into a so-called diagnostic pipeline. So to maintain that was quite difficult and quite challenging, because you had so many different approaches, and in the end there is only one result. So either it's positive or negative, and a lot of follow-up questions like what is the CT value, what is the lineage, and everything. So when you have such a diversified pipeline of diagnostic, you have to know how these methods are interchangeable among them. And we one of the studies that we had to do is actually to look how these systems were compatible. And because you know that in many countries, the CT values became a proxy for infectivity and infectiousness and transmissibility. And of course, every good molecular scientist knows that this is really influenced by so many other factors, not just copy number. And it's not that easy. So we knew that, and we showed in the study that actually just in our pipeline, which was quite diverse. So this is, in the end, this is our pipeline. So we had very, very many diversified methods that were amplifying different targets in the genome, and they all came together to the lab report. And just between them, if you compare the CT values in the same, so the same sample run through the different pipelines, there was actually there was about 6, from 3 to 8 CT values difference, just because of the input volumes and output volumes and the gene that we were amplifying. So in the end, we realized that actually using a CT value as a proxy for infectivity is really not a good marker, unless you can do it always in the same pipeline. But if you have, if you're from such a small country like we, this was just not possible during the diagnostic. We had a lot of intensive communication, especially with intensive care unit, that maybe for them we could do it in the same platform, but it was just the chain of supply and reagents was so unstable that you just couldn't do that. So in the end, really to optimize the microbiological diagnostics in the lab, we had to talk about transport. We had to talk about digitalization of not just microbiology, but also the health system, sorry, the public health system. We talked about barcoding samples, and we actually achieved that all our swabs, in the end of pandemic, our swabs became labeled with barcodes, and they could be automatically inserted into our laboratory information system. We talked a lot about comparability and traceability of the results. And in the end, not to bore you too much, but just to emphasize, the storage is a big question in this case. And I think we, as a research and scientific community, we have to think about it in our preparedness plan. We have to think about it in advance, because I know that we put a lot of money and also a lot of care into that we were able to aliquot and store samples. And this is now the basis for the research. And there's a lot of institutions that were just not prepared in this way and were not able to do that during the pandemic. And I think this is really the point where the scientific community lost, because these are the samples that cannot be get back later on. So you have to do it there. You have to make this extra effort at that point of time, even though you're so tired and overworked that you don't know why actually you are doing that. But we have to make sure as a society that we bring in the preparedness plan also the problem of storage, and of course also the problem of waste in the planning, because otherwise when the epidemics happens, we are just not prepared. So this is the curve of epidemic in Slovenia. So here is the first wave, you cannot even see it, but then it's the second, the third, and here somewhere at the end of also the monitoring of variants came in play here in the beginning of 2021. And then in 2022, in January, we like the whole world, basically, we had the Omicron wave. And because it was so massive, the government and the public health and everybody agreed that we should stop the mandatory testing and confirmation of every single person that was getting positive on antigen tests. So in January 2022, our laboratory did more than 180,000 PCRs. So you know what that means. That means like 10,000 PCRs per day, every single day, actually, to get to this. So this was really massive. And once this was stopped, basically the workload really significantly diminished, and everybody was talking about end of pandemic, and there is no more COVID, so we can go back to normal. But in the fact, if you work in a diagnostic laboratory, it was maybe end of pandemic, but it was definitely not end of transmission, and it was definitely not end of testing. Just the testing a little bit shifted and it was changed. And if my own opinion is, it was more focused in the groups that is actually more relevant in terms of that we, at that point, we already had pharmaceutical interventions, we already had the vaccine. So I think it was the time that we change who gets the priority for testing, because otherwise we just put a lot of effort into really not obtaining a lot of information. So if we look at the end of year 2020 and then 2023, how the diagnostic, what became of diagnostic of SARS-CoV-2 in Slovenia. So after the Omicron wave, the diagnostic requests significantly dropped, but they never went to zero. Even in 2023, we still did about 18,000 samples just for the SARS-CoV-2. Instead of wide public testing for asymptomatic people, we really focused on hospitalized patients. We really focused on special groups like immunocompromised patients. We have a lot of requests from the Oncology Institute and hemato-oncology departments, because in these patients we see really a long-term infection and prolonged, not just PCR positivity, but also prolonged infection. And this maybe in the sense of, for us it's interesting in the sense of evolution and in the sense of, basically evolution of SARS-CoV-2, but for the patients this is really important in the sense of their receiving their own treatment for their primary actually health problems that we have. And a lot of focus was shifted from just getting the PCR positive to really to get the information about viability of the virus and actually to monitor the viral variants. And like I showed previous, we really put a lot of effort in establishing the next generation sequencing department in our institute, and also really to promote sequencing in Slovenia, because before SARS-CoV-2 epidemic, the next generation sequencing was basically done just for the human genomes, for the oncology department and from the human health side. But in microbiology, we were still mostly in Slovenia sequencing only sporadically, and or if we were doing the genetic monitoring, we were doing it on one gene, mostly with the standard sequencing. But with viral variants, we realized that actually we have to amplify our and to focus our needs more into the monitoring of viral variants. So altogether, our Slovenia actually put such an effort into the sequence surveillance that in the end we yielded with more than 41,000 complete genomes of SARS-CoV-2, which is, for me, is still a massive change. And if in 2020 somebody would say to me that we were able to come from 0 to 41,000 in 2 years, I wouldn't believe it. But now I know that we could even do better if we would have the knowledge that we have now. But regarding the surveillance, we give weekly SARS-CoV-2 surveillance report that are available at our website, and they're available for clinicians and for epidemiologists, and also for the public to really as a tool to understand what's happening with, because the messaging of massive testing and then stopping of testing is also a very confusing message for the public, because for them it's like, it was all about big deal about COVID pandemic, and now it just stopped, but people are still sick. So if you want to have a public on your side, if you're a diagnostic laboratory, then doing a surveillance and publishing the surveillance and talking about it is also a very important job. So I like this slides, not because it's informative, but it's just it's really interesting that we are able to see really this live evolution of SARS-CoV-2 in such details that we were not even I was there even for Ebola work, and we look at this whole genome sequencing and epidemiological surveillance of cases in Ebola, but here in SARS-CoV-2 we see it in such details because there's so many genomes available that in the end it looks more like an abstract picture of some very famous painter than metagenomic data. But you see that there is a very the virus is still, it's like Julian nicely showed, it's not less mutating, but it's even more mutating. It's widely adapting to its environment. It's adapting to the changes in the changes in the environment, which happen because of other measures that we put in. So, but for me, I come from the zoonotic laboratory, and I switched a little bit to the respiratory side now, but I still stand somewhere in between. But it was very interesting how the pandemic shifted not only the SARS-CoV-2 diagnostic, but the whole respiratory virus diagnostic. So you see, here is the graph based on the data that Professor Petrovets and his group provided. So from 2018, you see how the incomes, the requests for the respiratory viruses came in. And now here is just, sorry, here are the other respiratory virus requests during the pandemic, and here is the stop of pandemic, and here is 2023. And you see that, first of all, there is increased demand for testing. So not just, there is really the public, the clinicians, the patients, they all expect to be tested more. They expect faster turnarounds. They expect that their results will have informations like viral loads, CT values, genetic lineages. They expect to have information on viral dynamics, on infectiousness, and all this shapes how the diagnostic laboratories have to adapt, because now we have to facilitate all these requests, and we have to know what is actually what is important for clinicians, what is important for public health, what is important for patients, and what is feasible with the amount of money and the workforce that we have. So after the pandemic stopped and the testing continued, so this is early 2020, from April 2002, we decided to do a small experiment, and we introduced a 4-plex assay that simultaneously detects SARS, influenza A and B, and RSV. And we tested the period from February to April. Instead of testing them just for SARS-CoV-2, we tested them for all 4 viruses just to see what is out there. Because if we don't look out there, if we don't look at this field, then we look only, like it was nicely presented for animal health, if we don't look at this, we don't know. So even in this is so really after the big Omicron wave, we found the continued strong dominance of SARS-CoV-2, which was not surprising, but very, very early after the stopping of non-pharmaceutical measures in the population, we already saw the comeback of influenza A and B, and of course RSV even sooner. So even in this very active phase, we already had about 3% of cases that had other important respiratory viruses. And what we saw And what that really prompted us was that we had a high percent of negative samples, but they were still inpatients. So these were hospitalized patients, but they were negative for these 4 pathogens that we tested. And this was not such a low percentage. So that's why we decided that we have to invest into this matter further and to look it further. So we decided that in this winter 2002 and 2003, we will not use the single-plex SARS assay, but we will use 4-plex assay for every diagnostic request that comes for SARS or for other respiratory, like for flu or for RSV, in order to get as much combined data as possible and to see what our future of diagnostic of respiratory viruses would look like. So this is the we have just finished with the analyzing the period of from October 2002 to April 2023. This is something what my respiratory colleagues would say the season of respiratory viruses. And you see that, so the SARS is the green one, but the scale is on the other scale. So it's diminished, intentionally diminished, so that you can see other infections. So we still had a lot of SARS infections, but we had very early on the RSV detections, we had the flu, and as the season progressed, we had more and more flu A infections and less, and in this case also then less SARS infections. And what we saw, there was also co-infection. So in this period, we had about we tested 18,000 samples, and about almost 10% of them had SARS-CoV-2 infection, about 3.5% had flu A infection, and 2.8% it has RSV infection. But these are not, for me, these are not the most important take-home messages. For me, more interesting or more important are the co-detection infection, whatever you want to call them. And of course, when we have higher the field, more the infections in the field, better the environmental conditions, more co-infections we see. And if we look at different co-infections, we see that this blue is SARS and this red is flu A, and this 15 is actually the number of co-infections that we have. And what was interesting that in this first testing period from February 22 to April 22, we had about 3% of co-infections already. At the very end of pandemic, we already saw the 3% of co-infection. And in the whole season of from 22 to 23, we also saw about the same percentage of co-infections. Of course, we saw more testing, but the percentage was about the same. So this means that these viruses are really susceptible to the preventive, non-pharmaceutical preventive measures that we introduced, but are also very resilient in coming back once we stop using that. So they are there in the environment and they are ready to come back. This is also very interesting. Maybe it's a little bit difficult to understand at first, but you hear a lot about the seasons and seasonality of different viruses, and we all look at that. And there's a lot of rumors, and not just rumors, but also real talk about, will the SARS-CoV-2 ever be a seasonal virus or not? We'll see more infections because the winter is coming, or is this relevant to something else? So in this graph, we see that the blue line is the RSV infection, and it was the first that came up, which is very normal for the RSV to be very early in the season. Then it was, because this graph presents, sorry, maybe I should say that first, but this graph represents the percentage among the positive, the percentage of different infections. So, and the black line is the percentage of the positive. So you see that throughout the season, we had about from 10 to 20 of positive cases tested, so no big surprise. And we see the really seasonal distribution of RSV, flu A, and the later peaks of flu B. But if we look at the dynamic of SARS, we see that actually it's not the season, it's not the environment that's influencing the SARS, but it's more the playground of that different viruses. So the percentage of how much SARS did we detected in this, our symptomatic hospitalized patient, was more influenced by how many other viruses we detected, not but by if we're talking about the month of infection. So it's not really, I would say that it's not really a seasonal virus, but it's a virus that will be very much, the prevalence will be very much connected with the prevalence of other viruses. So this, what I showed you, and actually also this, where we showed that in the season 2023, we had a lot of hospitalized negative patients for the fourplex, and the diagnostic background on respiratory viruses that we have prompt us really to look at this issue more in depth, and we wanted to see, we predicted that there will be a very high diversity and simultaneous circulations of different respiratory viruses. And these are the slides that were kindly led to me by the group from the respiratory viruses, and they go way back from 2018, and you see the flu, RSV and flu dynamic before the SARS, during the pandemic, and now after the pandemic. And you see that they really we tested here, but they were not present. So all the preventive measures that we used to stop the SARS pandemic, and they didn't work on SARS, they actually worked on they worked on flu very well, and they also worked on RSV. But as soon as we took down the lockdown, we see the RSV came back in a very high rate and very intensive rate. And now, after the end of pandemic, in this year, we see a lot of infection. We see a little bit higher numbers of RSV and longer peaks of RSV in our population that we saw before, but we also see much more testing than we saw it before. And here is the example for, it's the same graph, the same area, and we are always talking just about hospitalized patients. And it's for human coronaviruses, but Monica already showed you, so I won't bother you with that. But it's also, in the same graph is also the rhinovirus. So none of this is, again, the background is the SARS epidemic, and none of our measures really influence the rhinovirus circulation in that. So what does this mean? If the rhinovirus becomes more pathogenic, we will have even bigger problem than for coronaviruses. I don't know, thank God I don't work on that, but but this shows, for me, this was really surprising, because even in the lockdowns, you could see the circulation of rhinovirus, like almost non-interrupted. And what we see now, even higher, of course, yeah, there is a higher testing of all the viruses, but very high percentages of positive for rhinoviruses. And this year, for example, during the summer, I think the season didn't even stop. So we saw the rhinovirus infections throughout the whole summer and are even amplifying now. And this is the last graph I want to show you. So it's for adenovirus and the parainfluenza viruses. The same graph, the same area, again, hospitalized patients. And you see that although the adenoviruses are in red, and they are lower than, for example, rhino and everything, but still no preventive, non-pharmaceutical preventive measure, no lockdowns really touched the adenovirus. We saw the infections in hospitalized patients throughout the pandemic, and we see even more now. And the parainfluenza is usually peaks out in the summer months. So we see more infections in the summer months, and it is about, again, we see it more because we also test more, but we see practically unchanged epidemiology as we did before. And taking all this together, it's the graph that you already saw today, just a little bit different perspective. It's the whole, like Monica nicely put it, is the whole ocean outside. So this is the 10-year period of respiratory samples, and here is the SARS-CoV epidemic, and you see that yes, some seasonality was changed, but they're coming back again. So we didn't really, we just like broke the pattern, but not really stopped the circulation of any respiratory viruses. So what do I think is coming next? I think it's going to be a very interesting season. I think we really are going to see a lot of co-detections, and this is one of the things that were already mentioned. We see maybe not so many co-infections at the same time, but we definitely see consecutive infections. And because we also use more and more sensitive techniques, so we see like longer peaks of infection because we are able to detect one genome copies. So maybe in the future, if we want to understand this graph further on, we have to see, we really have to monitor all of them, but we have to also look at the quantity of this virus in terms of symptoms and in terms of hospitalization. So with that, I would like to acknowledge all the work that was done. This is definitely a team effort. It was done by all the colleagues that were working in the laboratory diagnostics. Of course, without infectious disease specialists, clinicians, and everybody else working very diligent before pandemic, through pandemic, and then now afterwards, this would not be possible. And special thanks to all the colleagues that really participated, that daily participate in this work. Thank you.
Thank you, Misha, and the podium is open for question.
Thank you very much. What about the reported disappearance of the B. Yamagata that supposedly in most places in the world has not been isolated since about March 2020? So about the disappearance of B. Yamagata. So supposedly that hasn't been isolated since about March 2020. So can you distinguish with your bees between the two lineages?
Yeah, we can distinguish, and we didn't, so maybe you should, but we didn't detect it as far as I know. We can look at the data a little bit, but yes, we did, as far as it was gone also in our data.
It's fascinating. Thank you.
Yeah. I think for me, it was also very fascinating. I don't know, maybe people were doing more genomics were not so surprised, but for me was, for example, very surprised how one lineage really very fastly completely wiped out the previous lineage. Because, I don't know, from my virological background and understanding, I would expect that this process would be a little bit, more competitive. But here, especially in coronas, it really looks like it's really wiped out the whole population. I don't know, maybe this, for me, but I might be completely wrong, so maybe Julian will correct me. But I think it might be also because, we get this quite good immunity, but it's very short-lived, really short-lived. It's like, I think it's even less than 3 months short-lived. And so if you have infectious virus and very short-lived immunity, then this could be one of the explanations why we see like a very dramatic spread of one variant and then really very rapid change to another. But I might be wrong. Oh, thank you.
Thanks, Julian.
So yeah, I think we are a little bit behind of time. So if there is, yeah, of course. Oh, I don't see you.
I'll be quick. It's a lot of testing that you've done Wales is 3 million people, Slovenia is 2 million people, but still 500,000 tests. How much testing is enough, and for what purpose should we do it? Or were we just increasing the amount of tests as a proxy for a feeling of safety, rather than controlling it in sensible ways and directing our resources to other places and other things?
Very good question. I don't think I'm smart enough to answer that question, but this is the question that we were actually asking a lot around January 2022, because we just didn't see any point in really putting so much effort and so much money into just like, I don't know, sometimes I had a feeling that I work in a governmental office dealing the driver's license, just like, you know, yes, positive, no, not positive, and no impact on the pandemic, no impact on the health, nothing else. So that's why we really strongly try to take across the message that we have to focus on the groups where this matters, not on general population. But I still believe that for oncology patients, immunocompromised patients, these are very important questions, and we have to test even more. I think that also the work that Gasper presented on critically ill patients, we just don't know enough. I agree that it would be really sensible to have this information even before COVID about herpes viruses and about other respiratory viruses also in critical ill patients. I think that would help with their management, but we really have to focus. And for preparedness, I believe in One Health paradigm, and I think we have to look much, much broader, not just like test. Like, I just also think not just like sequence everything, but we really have to find what is the right, and this is, of course, this is what we try to find, what is the right amount to get the information soon enough to be able to actually predict, or to at least stay on top of that. And I think this was your question on I really like it when you ask the people working with artificial intelligence when we will be able to calculate something like that. So I know my answer is not perfect, but this is really the main question. Thank you for that.
If I may, if I may just make a very short comment, 30 seconds, just to understand the policy, which is before COVID, and it's now going in the same direction, is the population, as Misha mentioned. But we, long time, when we start doing a PCR, we decide that we have two forks of looking for what is going around us. One fork is patients are tested only if they reach the point of hospitalization. So if they would be hospitalized, they would get the molecular test. If they would be sent home, they would not be tested. But there is other fork, which is covered by the public health laboratories, which have a sentinel for the flu tracking. So they, instead of testing just the flu as before, they test also the COVID and RSV. So this is maybe the state right now. We are quite comfortable because we are really covering anyone hospitalized in the clinical center, which covering more than half of Slovenia, and especially all the severely ill patients. And they are now sensitized enough, especially for hemato-oncology, to test them when they have even a minimal symptoms. And one of the experience is, like before COVID, that flu infections spreading in the hospital very often starts in the cardiology department, because the patients get deterioration of their own disease, to say so, and nobody think that there is a flu who making them so vulnerable they need to go to hospital. So we are really focusing on these experiences to cover all these areas. So I would say that we are quite confident that there is a very little which could go under the radar as long as it gets clinically so severe that they would end in the hospital. This is just the last remark. So, and you're invited to coffee break right now. Thank you.